Hi, my name is Melissa Meyer, and I am a PGY3 resident at the University of Wisconsin in Madison. Today, I will be discussing a study entitled Ahead of the Curve: Which Growth Curve Best Predicts Small for Gestational Age Infants in Obese Women? I have no conflicts of interest to disclose. Fetal growth restriction, or FGR, is a common entity in maternal fetal medicine with known associated adverse outcomes. Neonatal risks are decreased if fetuses at risk for small for gestational age, or SGA, are identified in utero. Therefore, accurate assessment of fetal growth restriction and its ability to predict an SGA infant is vital. Ultrasound is the standard method to evaluate fetal growth. The most commonly used definition of growth restriction is an estimated fetal weight less than the 10th percentile, with abdominal circumference alone less than the 5th percentile also utilized. There are multiple growth curves that have been studied, with common growth curves including Hadlock and Brenner. Currently, additional customized growth curves are being studied, such as Intergrowth 21, the WHO, and the General Global Reference. Recent research has sought to identify which growth curve is superior in predicting a small for gestational age infant. A study in 2019 concluded that Hadlock was more sensitive and Brenner was more specific. Another 2019 study found that Hadlock was better able to predict birth weight percentile. With the increase in maternal obesity in the United States, it is important to consider the impact of maternal obesity on these growth curve results. It is known that maternal obesity can present a challenge in assessment of fetal anomalies by ultrasound. However, multiple studies have shown no significant difference in ultrasound evaluation of estimated fetal weight in obese versus non-obese women. However, a study in 2009 found that there was an increased rate of missed SGA diagnoses in overweight and obese women when using population-based growth curves compared to customized ones. Therefore, the most accurate ultrasound method to best predict a small for gestational age infant in the obese population has yet to be determined. Objectives of this study were to determine if prediction of SGA infants using standardized ultrasound growth curves is affected by maternal obesity, and to determine which growth curve performs best in obese women. Our hypothesis, based on data from the general population, was that the Hadlock growth curve would perform the best. This was a retrospective cohort study with data collected from June 1st, 2018 to June 1st, 2019. Data was collected from a single institution, the University of Wisconsin, for all growth ultrasounds from 30-week 0 days to 32-week 6 days. Patients were excluded if they had a multifetal gestation or a fetal demise. At our institution, the Brenner growth curve was utilized to determine estimated fetal weight prior to January 1st, 2019. After this time, all estimated fetal weights were determined by the Hadlock growth curve. Abdominal circumference was determined by the Hadlock growth curve throughout the entirety of this study period. Definition of fetal growth restriction was based on estimated fetal weight of less than the 10th percentile and/or abdominal circumference alone less than the 5th percentile. Actual birth weight percentile was determined based on World Health Organization standards and Fenton growth curve standards for term and preterm infants, respectively. Maternal obesity was defined using standard body mass index definitions as listed. Statistical analysis was performed using STATA. Analysis included contingency tables to compare predictive statistics for SGA infants at birth. Area under the curve analysis was then used to compare the different growth curves. We then performed additional analysis based on class of maternal obesity and BMI. 3,286 ultrasounds were reviewed. After employing the exclusion criteria, 763 ultrasounds were utilized in this study. There were 457 non-obese patients and 302 patients with obesity, or those with a pre-pregnancy BMI greater than or equal to 30. 77 infants were SGA, with 62 in the non-obese population and 15 in the obese population. Table 1 shows maternal demographics. The average gestational age at the time of the growth ultrasound was 39.1 weeks. The average pre-pregnancy BMI for all patients was 29.51. Specifically, the average pre-pregnancy BMI in the non-obese population was 23.76 and in the obese population, 38.23. Overall, the Hadlot growth curve performs superiorly to other growth curves. When comparing the Hadlot growth curve in non-obese and obese populations, maternal obesity significantly decreased the ability to predict SGA compared to non-obese patients. Area under the curve was 0.58 in the obese population compared to 0.73 in the non-obese population. The p-value was 0.02. When looking at all four growth curves, there was no significant difference in the ability of the other growth curves to predict SGA between obese and non-obese women. In obese patients, there was no significant difference between ability of the four growth curves to predict SGA, with p-value of 0.41. In non-obese women, Hadlock outperformed the other three growth curves, with p-value less than 0.01. In conclusion, all four growth curves performed poorly in obese women to predict a small for gestational age infant. While maternal obesity appears to decrease the ability of the Hadlock growth curve to predict a small for gestational age infant, Hadlock performed best of the growth curves studied in this population. As always, this study has its strengths and limitations. Strengths of this study include its ability to directly compare different growth standards in a similar population at a single institution. This direct comparison is a helpful first step in identifying which growth curves will be best predictive of SGA in the obese population. Limitations of this study include its retrospective data collection and its assessment of fetal growth at one time point in pregnancy. Areas for future study include an evaluation of the indications for growth ultrasounds in these patients. This might help to determine if specific indications, such as fetal anomalies, have a greater impact on the ability of a growth curve to predict an SGA infant in the obese population. Additionally, similar evaluations at different gestational ages and based on amount of maternal weight gain could add additional perspectives to this research study. All in all, this study is a first step in identifying added challenges in ultrasound prediction of SGA infants in the obese population. Additional studies will be beneficial in determining the best growth curve to use in this high-risk population. I would like to thank my co-authors and the Division of Maternal Fetal Medicine at the University of Wisconsin-Madison. Thank you for your attention.